Clinical and radiological features predicting severity and response to therapy in children with post-infectious bronchiolitis obliterans. Dr. Nagarjun.
Good morning. I'm Dr. Nagarjun. I'm a fellow in pediatric pulmonology. Today I'll be presenting predictors of severity and response to therapy in children with post-infectious bronchiolitis obliterans. As we already know, PIBO or post-infectious bronchiolitis obliterans is an uncommon and severe form of chronic obstructive lung disease. Though we mentioned as uncommon, it's become a very common disease that we see nowadays in the Indian population. It develops following a microbiological insult to the lower respiratory tract. Most common organism that has been isolated is an adenovirus, serotype 3 and 7. The signs, symptoms, and prognosis of PIBO vary. Confirmative diagnosis of PIBO requires histopathological examination, but since it's an invasive and challenging due to clinical instability of the patient and heterogeneous distribution of the lesions, currently the diagnosis is often made by a high-resolution CT. So the aim of our study was, since there was no dedicated study that was able to classify PIBO based on HRCT thorax and clinical findings to help determine the management, we investigated the clinical and radiological features of severity and response to children with the PIBO. Objectives of our study were to identify predictors of severity of post-infectious bronchiolitis obliterans, both clinically and radiologically, and to develop a severity classification of PIBO to aid management. Materials and methods. Type of study, it was a prospective descriptive study conducted at a pediatric pulmonology clinic in Bangalore. Duration of study was 1 year. Inclusion criteria include a history of admission for a bronchiolitis or a viral pneumonia in a previously healthy child, evidence of persistent airway obstruction after the acute event, which is identify a physical examination, or with history of more than 6 weeks of continuous wheezing, persistent cough, and tachypnea, as per the WHO standards, or a poor response to an inhaled corticosteroid for more than 2 weeks. Radiological assessment of a CT thorax was done. Thorax was performed in all the children at the time of diagnosis. The mean thickness and standard deviation of the CT scans were 2 plus or minus 1 mm. CT scans were quantitatively analyzed by one radiologist who was blinded to the clinical course using dedicated imaging analysis software. HRCT findings that were mainly looked for were mosaic attenuation. Sorry, sir. Yeah, mosaic air trapping pattern, atelectasis, inflammatory bronchiolitis, bronchial wall thickening, and bronchiectasis. So we had our arbitrary clinical severity classification. We classified children into the mild category with just presence of wheeze for more than 6 weeks, in the moderate category with persistent wheeze for more than 6 weeks, with tachypnea and retractions, and in the severe category, the moderate category plus persistent oxygen requirement or recurrent history of hospitalizations. HRCT severity classification. In the mild category, we included ground glass opacities or air trapping. We divided the lung into 20 segments, and based on the number of segments, we classified the severity as mild, moderate, severe. In air trapping of segments involving 1 to 6 segments, we classified it as mild. In the moderate category, it was between 7 to 12 segments, and in the severe category of 13 to 20. In the moderate category, we also considered inflammatory bronchiolitis and atelectasis as a feature, whereas in severe, we considered the moderate category with air trapping, bronchial wall thickening, and bronchiectasis as a severe category. So severity, both based on the clinical and radiological features, we treated the child based on mild, moderate, and severe PIBO. In the mild category, we just treated the children with inhaled corticosteroids. Moderate category, we treated with inhaled corticosteroids, azithromycin for a period of 6 months, and oral steroids as a tapering dose over 6 weeks. In the severe category, we treated with inhaled corticosteroids, azithromycin, pulse methylprednisolone with or without hydroxychloroquine. Response and follow-up. Children were known to have response mainly based on clinical parameters. In the mild category, with the absence of wheeze. In the moderate category, in the absence of retractions and tachypnea. In the severe category, all of the above, plus or minus absence of oxygen requirement or repeated hospitalization. The patients were followed up at a 6-week, 3-month, and the 6-month interval to monitor response to therapy. Those patients who did not respond adequately at each visit were escalated to the following group. These are the results of our study. Study included a total of 36 patients. There were 22 boys and 14 girls. The mean age of the CT diagnosis was at 3 years, plus or minus 2.2 years. In the mild category, we had 10 patients, moderate 14, and severe 12. The ratio of the male to female ratio was 6:4 in the mild severity range. Moderate it was equal, and in the severe it was 7:5. As I already said, following a clinical and radiological classification, we divided them into mild, moderate, and severe. And most of the clinical characteristics, cough was a predominant characteristic. in 86.6%, followed by V's in 83.3%. Oxygen requirement were, however, noted only in 3%, three of our children, and recurrent hospitalization in 10. HRCT thorax characteristics. As we see, mosaic attenuation was the most common feature in almost 70% of our patients, followed by air trapping in 47% and atelectasis in 38.8%. This is the HRCT thorax severity characteristics in the mild, moderate, and severe groups. As you see, again, in the mosaic attenuation, we have a majority of the patients. Most of the patients had mosaic attenuation, and bronchiectasis were present only in a severe group. Treatment responses, we divided the children in the, we followed them up at 6-week, 3 months, and 6-month course. In the mild course, at follow-up only on the inhaled corticosteroid, the responders were 100%, and all of the children had no issues during the 3-month and 6-month follow-up. In the moderate criteria, the responders are only 78%, so we had 3 non-responders who we eventually shifted over to the severe category. The responders in the moderate criteria at the 3-month and 6-month follow-up did not have any issues. In the severe category, initially only on the pulse methylprednisolone, there were 67% responders, and non-responders were 33%. And then we introduced hydroxychloroquine at the second visit, and when we followed them up again at a 6-week, 3-month, and a 6-month interval, they didn't have noted to have adequate response. As I previously mentioned, the moderate category, those non-responders were escalated to the severe category, and once we started them only on IV pulse methylprednisolone, follow-up at 6 weeks, 3 months, and 6-month age, they were shown to have adequate response. Discussion. Our study is the first study which showed that PIBO patients can be classified based on both clinical and radiological criteria. All patients in the mild category responded to the inhaled corticosteroids only. 21% of the moderate category needed to be shifted to the severe category, and during follow-up, they showed adequate response. 67% in the severe category responded to IV pulse alone, and 33% required to be started on hydroxychloroquine, but on starting and following up at 6 3-month and 6-month interval, they're shown to be well. As I already said, we treat our PIBOs only with ICS only in the mild criteria. Moderate oral steroid for 6 weeks with ICS and azithromycin. The severe PIBO with pulse methylprednisolone, ICS, and azithromycin with or without hydroxychloroquine. We usually want to closely monitor these children for a period of 6 weeks, 3 months, and 6 months. Failure of response to treatment needs to be escalated on therapy. Our outcomes, none of the patients had repeated hospitalization after initiation of treatment in our study. There was 0 mortality was observed in our study. At 3-month follow-up, no child in the severe category had any oxygen requirement. To conclude, to the best of our knowledge, this is the first study to show that clinical and CT findings may be useful for predicting which child in the PIBO are likely to respond. We also like to highlight the role of using our novel clinical and radiological criteria to classify PIBO. This enables the physician to determine appropriate treatment in children with PIBO, which adds value to future studies in this area. Thank you.
Thank you. Any questions from the audience?
Excellent presentation, congratulations.
Thank you.
You had 36 patients. None of your patients had oxygen requirement after 3 months.
Yes, sir. We had
so your diagnosis of BO was based on the initial CT scan. Is there a possibility that this could be just a post-viral wheezing which continued for a prolonged period of time? How did you rule out other causes of BO in these children? Did you do aspiration study, systemic inflammatory diseases? How did you rule out? How did you label that this was actually a post-infectious bronchiolitis? Because you had a large cohort of 36 patients in 1 year, which seems slightly interesting.
Yes.
And yeah.
Thank you, sir. So mainly our diagnosis is based on our clinical criteria. Since as a referral center, we do get a lot of patients from various institutes. We have diagnosed only on clinical criteria with a history of a respiratory tract infection or a severe bronchiolitis, and even after, despite treating with adequate doses of oral steroids or inhaled corticosteroids, some of the children have not responded. And then we did the CT, that was when they presented to us, and the CT findings, when compared to the other studies that have been done on PIBO, were correlating, and that is why we treated them as PIBO, sir.
More question.
So very excellent presentation. So what is the characteristic feature of CT scan? It is a GGO or the air trapping? Because in mild there is only GGO, and in moderate you have the air trapping. So what is the pathologic, or you can say the characteristics feature in the CT scan?
Characteristic feature according to most of the studies is a mosaic attenuation, sir. Followed by that you have air trapping, which we were able to correlate in our study. Only the severe ones have bronchiectasis or bronchial wall thickenings.
I'm
Thank
asking
you.
because in mild only there is a GG or there is no air.
I think the next session is waiting to start. We'll have one last question and then we'll wrap it up.
Actually, this atelectasis and bronchial wall thickening, these are the 3 points you have mentioned. And after treatment, the patients improved. Did you perform any subsequent CT for actual improvement of the lung pictures?
No, sir. We actually only monitored the children clinically to consider radiation as an
Radiation hazard.
So we didn't do the repeat CT.
Thank you.